But before we get too far ahead of ourselves, I want to briefly establish where this information is coming from. We are drawing directly from cornerstone medical texts, including Sims' Symptoms in the Mind and Fish's Clinical Psychopathology. This is the peer-reviewed foundation of psychiatric evaluation. So we aren't just tossing around theories today. We're looking at the exact frameworks clinicians actually use to understand their patients.
Here is our roadmap for the explainer. First, defining the delusion. Second, the binary problem. Third, Kendler's 5 vectors. Fourth, emotions and actions. And finally, why dimensional severity matters.
Okay, Section 1. Defining the delusion, the old guard.
Let's look back at how early psychiatric pioneers originally tried to tackle this. For a long time, the standard approach was to use Carl Jasper's 1959 criteria. Jaspers created this very specific black-and-white checklist. For a belief to be an official delusion, it had to be a false judgment, held with extraordinary conviction, totally impervious to counter-arguments, and the content itself had to be physically impossible. So a clinician would just look at this list, and if a patient checked these boxes, boom, they had a delusion. It was a highly rigid, categorical way of looking at it.
Which brings us to Section 2, the binary problem, a clinical puzzle.
This raises a huge question. Do human minds actually fit perfectly into those rigid little diagnostic boxes? Well, no, of course not. And this perfectly illustrates what we call the binary problem. Jasper's view was binary. A delusion was either present or absent. But out in the real world, clinical complexity is incredibly messy. Like, what happens when a patient's conviction fluctuates from day to day? Or, get this, what if the delusion actually corresponds to objective truth? Imagine a case of delusional jealousy. A patient might have a profoundly disordered belief that their spouse is unfaithful, and it turns out the spouse actually is cheating on them. The belief isn't objectively false, but the way the mind arrived at it is entirely delusional. Normal beliefs can be held with extraordinary conviction, and delusional beliefs are sometimes amenable to counterargument. Those rigid boxes, they just weren't cutting it.
So clinicians were stuck with this massive puzzle, and it stayed that way for decades, right up until the year 1983, when a major paradigm shift finally unlocked it.
Enter psychiatrist Kenneth Kendler. He recognized that defining delusions as simply present or absent was, practically speaking, clinically insufficient. He proved that delusions are heterogeneous. They vary wildly from person to person. So instead of a simple yes or no, he proposed evaluating severity across 5 independent, poorly correlated vectors. These are conviction, extension, bizarreness, disorganization, and pressure. Let's unpack exactly what each of these means.
First up is conviction. Basically, this is the degree of certainty the patient has in the reality of their belief. And what's super interesting here is how it breaks from the old model. Unlike Jasper's static view, where you're either 100% convinced or not at all, Kendler pointed out that conviction can actually fluctuate. It can ebb and flow over time, and crucially, it can scale down during treatment.
Next, we have extension. Think of this as the horizontal scope of the delusion. Sometimes a delusion is what they call encapsulated. It's neatly compartmentalized to just one tiny specific area of a person's life, and everything else functions completely normally. But a delusion with high extension, that bleeds into absolutely everything. It penetrates and alters every single aspect of a person's daily existence, their job, their family, their hobbies, the whole shebang.
The third vector is bizarreness. This one measures how far the conceptual content departs from culturally determined consensual reality. It asks, does this involve physically impossible phenomena? Because culturally, some unusual beliefs are perfectly accepted within specific peer groups or religions, but believing that, say, your internal organs were replaced by a foreign government overnight, that has a very, very high degree of bizarreness. Vector number 4 is disorganization. This is where clinicians look at the internal logic and the systematic architecture of the belief network. Basically, is the delusion a messy, highly fragmented jumble of random thoughts, or is it a highly organized, complex, and internally logical web? Some patients build these incredibly systematized delusions, where one basic false premise supports a massive, meticulously structured architecture of belief. It's wild.
Finally, we have pressure. This is the degree of cognitive preoccupation and behavioral urgency. It essentially measures the sheer amount of time a patient spends thinking about the delusion and how intensely they are driven to actually act upon it. Is it just a passing thought, or is it a burning, urgent obsession demanding immediate action?
This takes us to Section 4, Emotions and Actions, the human element.
We've looked deeply at the cognitive structure of the delusion,
But I want to pose this question directly to you. What about the patient's emotions and actions? If we're going to truly understand the real world and sometimes very dangerous consequences of these beliefs, we absolutely have to look at the human element.
To give clinicians a complete profile, the sources suggest two additional dimensions. First is the affective response. That's the intensity of the patient's emotional involvement, and it spans a massive spectrum. A patient might have an intense delusion but display this totally inappropriate indifference, which you sometimes see in schizophrenia, or they might be in a state of stark terror, like in states of delirium tremens. The second dimension is deviant behavior. This measures the extent to which a patient actually acts on their delusions. Now, not all patients act on their beliefs, but when they do, understanding the content of the delusion gives clinicians incredible predictive power for potential behavior.
And this brings us to a really powerful case example from the text that drives this all home. The sources detail a husband suffering from morbid jealousy. Because of his delusional belief that his wife was unfaithful, the behavioral pressure and deviant behavior were just immense. He obsessively interrogated her, checked her underwear, hired private detectives. He misinterpreted every innocent contact she had. Ultimately, it destroyed his family and cost him his job. This brilliantly illustrates how tracking these vectors, like pressure and deviant behavior, helps clinicians predict real-world behavior and step in before things escalate into physical danger.
Which leads us to our final section, Section 5, Why Dimensional Severity Matters.
To synthesize exactly what you should take away from this entire paradigm shift, the clinical impact of Kendler's work is just massive. By breaking delusions down into these fluid dimensions, rather than just checking a yes or no box, clinicians gain vital predictive power for a patient's behavior. It allows for highly nuanced treatment tracking. You can literally measure if the pressure or conviction is dropping as medication kicks in. And perhaps most importantly of all, it fosters incredible empathy. It forces the clinician to truly map out the patient's unique, terrifying reality in order to help them navigate out of it.
So, as we wrap up this explainer, I want to leave you with something to chew on. When we look at just how complex belief formation is, how conviction can fluctuate day to day, and how a belief's logic can be so deeply organized, where exactly is the line between a normal, deeply held human belief and a clinical delusion? It's a fascinating question about the fragile boundaries of our own minds. Thank you so much for joining me on this journey today.